Now we move on to the lower GI structure and function. The lower GI tract begins after the stomach, so the pyloric sphincter is the starting point. This leads to the small intestine or small bowel, which is coiled in the peritoneal cavity and is 5 to 6 meters in length. After the small intestine comes the large intestine or large bowel. Structure is 1.5 meters long and borders the small intestine almost completely. In addition, the accessory organs of digestion are included in the lower GI tract and include the liver, gallbladder, and pancreas. Structures serve to complete chemical digestion, then absorb nutrients and water from the digested food. Waste products are then eliminated from the body as feces. Additionally, the lower GI tract plays an important and ever-evolving role in immunologic function with its diverse microbiome. Similar to upper GI histology, the lower GI tract is composed of 4 layers: the mucosa, submucosa, muscularis, and serosa or adventitia. There are some differences as we progress through the lower GI tract. In addition to transportation, protection, and glandular secretions, the mucosa now serves to absorb nutrients and water through specialized structure found in the small and large intestine. Other 3 layers serve their same purposes in the upper GI tract. Another difference is with the serosa or adventitia. The lower GI tract connects with the mesentery, a membrane that facilitates intestinal motility, blood vessels, nerves, and lymphatics. The mesentery is a key structure in the function of the lower GI tract. The peritoneum is the serous membrane that surrounds the organs of the abdomen and pelvic cavity. It is analogous to the pericardium around the heart and the pleura around the lungs. Visceral peritoneum covers the surfaces of organs, while the parietal peritoneum lines the walls of the body cavities. The peritoneal cavity is the space between these layers and normally contains just enough fluid to help lubricate and prevent friction during organ movement. The mesentery, which we discussed being contiguous with the serosa or adventitia, is a fold of the peritoneum and holds portions of the small intestine in the peritoneal cavity. Organs may be intraperitoneal while held in these mesenteric folds, or retroperitoneal, if found behind the peritoneal membrane. The small intestine, though narrow, is in no way small. It is approximately 5 to 6 meters long and coiled in the peritoneal cavity. It is into 3 segments: the duodenum, jejunum, and ileum. Segments are slightly different from each other in function and histology, but not grossly different. Landmarks can help determine the segment being observed or worked with. We will examine these segments in the next few slides.
The duodenum starts at the pyloric sphincter and extends to the triates ligament, and is around 25 to 38 centimeters in a capital G-shaped curve. The duodenum is retroperitoneal and attached to the posterior abdominal wall. The duodenum is further divided into 4 divisions: superior, descending, transverse, and ascending. The most important features of the duodenum is the completion of digestion. The pancreatic duct, common bile duct, and the accessory pancreatic duct all empty into the duodenum. These provide pancreatic juices and bile. Pancreatic juices include alkaline bicarbonates to neutralize or alkalinize gastric acids, proteases, lipases, and other fat-digesting enzymes, and enzymes that further digest starches. Bile from the gallbladder and liver serve to emulsify or suspend lipids, allowing for fatty acid and fat-soluble vitamin absorption. Additional excretion of biliary wastes, like bilirubin, are facilitated through bile. An additional specialized feature of the duodenum is the presence of villus mucosa. This specialized mucosal tissue is found throughout the lower GI tract, but has differences in the different sections. In the duodenum, the villus mucosa appears as thick, finger-like projections of mucosa, which themselves have smaller fingers of tissue, known as microvilli, which increases the absorptive substances or surfaces of the small intestine. These circular folds of mucosal tissue are composed of absorptive columnar cells to facilitate nutrient transport, goblet cells which secrete mucus, and glands that secrete digestive enzymes. The specialized connective tissue in the mucosa also contains lymphocytes and plasma cells, which produce protective immunoglobulins. The primary nutrients that are absorbed in the duodenum are the fat-soluble vitamins, DAKE, water, iron, calcium, phosphorus, zinc, and copper. The next segment of the small intestine is the jejunum. It is approximately 2.5 meters long and has a slightly smaller lumen than the duodenum. It is suspended by the mesentery, which allows for mobility and flexibility during peristalsis, and is considered intraperitoneal. The contents of the jejunum are neutral to slightly alkaline, with a pH of 7 to 8 from alkalinization in the duodenum. While not vastly different in appearance, the jejunum is the major location of nutrient absorption in the small intestine. The villi of the jejunum are longer than the duodenal villi, and the jejunum has significantly less immunologic acidity than the duodenum and the ileum. The absorptive villi of the jejunum allow for intake of fructose, amino acids, small peptides, most water-soluble vitamins, and some fat-soluble vitamins, glucose, fats, alcohol, sodium, and potassium. Additionally, 90% of water absorbed through the GI tract is absorbed in the jejunum.
The last segment of the small intestine is the ileum. It is about 2 to 4 meters long and ends at the ileocecal valve. It too is suspended by mesentery and is intraperitoneal. The ileum has thinner walls and a smaller diameter lumen than the jejunum, and the presence of large immunologic and lymphoid tissues is found in the ileum. The ileocecal valve prevents reflux of large intestinal contents back into the small intestine. The ileal contents remain neutral to slightly alkaline. The villi are smaller and thinner than jejunal villi and serve to absorb remaining nutrients such as vitamin B12 with intrinsic factor, bile salts, and a small percentage of water. The villi also produce defensins, mucin, and lysozyme, which fight against microorganisms. Now we move into the large intestine, the final portion of the GI tract. It is approximately 1.5 meters long and divided into the cecum, appendix, colon, rectum, and terminating at the anus. The tissues here are gathered and bunched, making the large intestine look bulbous. The tissues here are also distinct from the small intestine, while still retaining the 4-layer scheme found through the digestive tract. The mucosal layer folds, forming rugae similar to the stomach, with spaces between known as crypts, but no villi are found. The first portion of the large intestine is the cecum, which receives chyme from the ileum through the ileocecal valve. It is located intraperitoneal. This pouch connects to the appendix on the right side of the body. The appendix is often known as a vestigial organ, or one that has little to no function in the body. However, in the past 2 decades, the function of the appendix has been rediscovered and is known to be a reservoir for beneficial microbiota. This means that when beneficial bacteria are flushed from the large intestine, such as with antibiotic use or diarrhea, the appendix can retain and repopulate the large intestine with those beneficial bacteria. The appendix can be removed without significant harm to the functionality of the body. The next segment of the large intestine is the colon. The colon is defined by its predominant haustra, or gatherings or circular muscles making pouches along the structure. The colon is further divided into 4 segments. The ascending colon moves up through the right side of the body, retroperitoneal. It absorbs remaining water and some nutrients. The transverse colon crosses the upper portion of the abdomen and contains major connections to arterial and venous blood. This section is intraperitoneal, as it has the most muscular activity of the large intestine. The descending colon moves downward on the left side, retroperitoneal, and serves to store feces. It also has a dense population of the gut microbiome. Lastly, the sigmoid colon is an S-shaped portion, which crosses the lower abdomen and is intraperitoneal. This section is very muscular and serves to move feces toward the rectum. The rectum is the terminal portion of the large intestine and descends downward in the body, intraperitoneal. Feces is stored here prior to defecation. Feces is the remaining food residues, unabsorbed GI secretions, shed epithelial cells, and shed bacteria, with some fats and water. Movement of the fecal mass into the sigmoid colon triggers the rectosphincteric reflex, an involuntary relaxation of the internal anal sphincter. The voluntary portion of defecation, which can override the rectosphincteric reflex, is known as the parasympathetic defecation reflex, which prevents passage of stool through the external anal sphincter. The GI tract plays a major role in immunity. In addition to it being an external epithelial surface, which is exposed to pathogens and antigens, it also contains gut-associated lymphoid tissue, or GALT. This tissue plays a major role in immune defenses by killing pathogens and preventing reactions to dietary antigens. The mucosal secretions produce IgA antibodies and antimicrobial peptides and lysozyme to defend against microorganisms. These are concentrated in the small intestine, especially the ileum. The microbiome of the GI tract is also of significant importance. The number and types of bacteria flora vary greatly and increases from proximal to distal in the system. The microbiome does not have major digestive or absorptive functions, but does play a role in metabolism of bile salts, estrogens, androgens, lipids, carbohydrates, nitrogenous substances, and medications. Additionally, they can synthesize antimicrobial peptides, hormones, neurotransmitters, anti-inflammatory substances, and vitamins. They also work to destroy toxins, prevent colonization by pathogens, and alert the immune system to potential infections. More recent research has demonstrated a connection between the GI tract and the CNS, or the microbiome gut-brain axis. This has implications for neurodegenerative diseases, developmental diseases, and psychiatric disorders. Let's move into the realm of the accessory GI organs. These organs primarily secrete substances necessary for digestion of chyme. The liver is a highly vascularized organ with vast networks of lymphatic tissues and innervation with sensory neurons. It has many metabolic, immunologic, and digestive functions. It is located on the right side of the body below the diaphragm and is divided into right and left lobes, with the larger right lobe being subdivided into the caudate and quadrate lobes. Liver lobules are formed of cords or plates of hepatocytes, which are functional units of the liver. These hepatocytes can regenerate, allowing a damaged or resected liver to regrow. From the perspective of digestion, it produces 700 to 1200 milliliters of bile per day. Bile is alkaline, bitter tasting, and yellowish green in color. It contains conjugated bile acids or bile salts, cholesterol, bilirubin, electrolytes, and water. Is formed by hepatocytes and secreted into caniculae, which lead to bile ducts, then the common bile duct and gallbladder. The gallbladder is a sac-like organ on the inferior surface of the liver. Primarily, it stores and concentrates bile between meals. Bile flows from the hepatic ducts of the liver and enters the common bile duct where it meets resistance at the sphincter of Oddi. Bile flows back through the cystic duct into the gallbladder and is stored until needed for digestion. The gallbladder absorbs water and electrolytes, making the bile more concentrated. It can hold approximately 90 milliliters of bile. Within 30 minutes of eating, the gallbladder contracts, forcing bile through the cystic duct and common bile duct, out through the sphincter of Oddi, and into the duodenum. Their bile helps with fat digestion and absorption, and bilirubin is excreted through the feces. Our final accessory organ is the pancreas. This 20 centimeter long glandular organ is tucked behind the duodenum, stomach, and extends to the spleen. Both endocrine and exocrine functions. Its endocrine functions are covered in the diabetes lectures in NERS 331. Briefly, the islets of Langerhans contain alpha, beta, delta, and F cells, which produce glucagon, insulin and amylin, gastrin and somatostatin, and pancreatic polypeptide, respectively. Functions derived from the acinar cells, found in spherica lobulis known as acini. They endrain secretions into pancreatic ducts, which empties into the common bile-duct and may branch into the accessory pancreatic duct. The cells produce bicarbonate, potassium, sodium, and chloride, which is alkaline to neutralize gastric juices. The cells produce amylase and lipase, among other digestive enzymes. These products drain from the common bile duct through the sphincter of Oddi and into the duodenum to facilitate digestion.